Welcome, everyone. My name is Ritu Kumar. I'm a senior principal advisor at Management Sciences for Health and will be moderating today's event. We're really excited to be here today and thank each one of you for joining us as we launch the roadmap for priority setting and health technology assessment. This is the culmination of several months of work and collaboration with global experts, many of whom are here today. The roadmap would not have been possible without the support of USAID, which funds the Medicines, Technologies, and Pharmaceutical Services Program, or MTAPS, the project under which the roadmap was created. We have a really packed agenda, which will kick off from, we'll have a kickoff from the leadership at MSH and USAID, brief presentations about the roadmap from the core writing team, and a panel discussion from HTA practitioners and experts from across the world. We will have time in the end for a Q&A. So let me start off by introducing Dan Kress. Dan Kress is the Vice President for Global Health Systems Innovation at MSH. Him and his team are responsible for the overall technical strategic direction of the organization. Dan has over 3 decades of experience working on health financing and health sector reform. He has held leadership positions at various global health organizations, including 13 years at the Bill and Melinda Gates Foundation. Unfortunately, Scott Stewart, the senior health economist at USAID, was unable to join us today, and we are really grateful that Lisa Ludman has stepped in his shoes right now. Lisa is a senior pharmaceutical management advisor with USAID Office of Health Systems in the Bureau of Global Health. She serves on the team managing MTAPS and the Promoting Quality of Medicines program. Lisa is responsible for providing technical guidance to USAID on matters related to pharmaceutical management and health system strengthening. Prior to joining USAID, Lisa worked with implementing partners such as MSH and Chemonics International on health and economic growth programs. I just want to remind the audience that there is a chat box that you can use to provide comments and questions as the speakers go through their presentations. And now I will hand it over to Dan to kick off today's event. Thank you, everyone.
Thank you very much, Ritu. Good day, everyone. As we just said, I'm Dan Kress, the Vice President for Global Health Systems Innovation at Management Sciences for Health. For those of you who don't know that much about MSH or may be unfamiliar, MSH is a global nonprofit focused on strengthening health systems to improve the health and lives of people living in low and middle income countries. We've long had a major focus around building capacity to strengthen systems locally. MSH will shortly celebrate over 50 years of work to strengthen health systems around the globe. Thank you all for taking the time to participate in today's event, where MSH and our partners are pleased to announce a roadmap for systematic priority setting and health technology assessment. This guide is intended to help countries make evidence-based decisions about how to allocate scarce financial and medical resources. Also, a big thank you to our partner, USAID, whose funding made it possible for us to develop this important roadmap. Today, you'll hear from the authors and from a fantastic panel of health technology assessment experts from Colombia, Kenya, Taiwan, and Ukraine. As COVID-19 strains healthcare systems across the world, particularly low resource settings, the need for good evidence-informed decision-making has never been so clear. What can countries do right now in anticipation of a COVID vaccine and novel therapies, several of which many worry will be very expensive, even potentially unaffordable for many countries? How can countries afford these new technologies with limited resources and so many competing priorities? These are tough questions. Health technology assessment is an important first step towards answering these questions, and is critical to making sure that scarce dollars are allocated efficiently toward health technologies. HTA, or Health Technology Assessment, is also critical to making progress towards NCDs, neglected tropical diseases, HIV, TB, and malaria, all of which COVID has thrown into turmoil. And last but not least, health technology assessment is critical to achieving universal health coverage and the need to set priorities in a systematic, transparent, and efficient manner, a commitment to which MSH has been dedicated for many years, as have I as a health economist throughout my entire career. I'm very much looking forward to your insights and engagement today. This work is critical, and everyone joining us today can be part of the solution. Without further ado, let me introduce the next speaker, Lisa Ludman of USAID, who will make a few remarks. Uh, B2 spoke real briefly about Lisa's career. As many of you know, she's been working with USAID on providing oversight on the Medicine Technologies and Pharmaceutical Services Program and promoting the Quality of Medicines Program. She's responsible for technical guidance USAID on matters related to pharmaceutical management, health system strengthening. She has a background in drug development, has worked in healthcare consulting on medicines access programs. Lisa, over to you.
Thank you, Dan. Thank you, Ritu. Good morning, good afternoon, and good evening, everyone. This is an exciting day for many of us who've been part of this global undertaking, the release of the roadmap for systematic priority setting and health technology assessment. Accessible, affordable healthcare is a cornerstone of high-performing health systems to ensure that all people have the care and treatment they need to improve their well-being without undermining their economic security. Ensuring healthcare is accessible, affordable, and high quality is often challenging, particularly for the countries where we work. With limited resources, policymakers have difficult decisions to make on which investments to prioritize. This raises critical questions. Which medicines, diagnostics, and procedures should they finance to achieve the best health outcomes for their constituents? What's the best way to do that equitably and transparently? With the COVID-19 pandemic, health resources are even further stretched to provide for new treatments, vaccines, diagnostics, personal protective equipment even, and other health technologies and devices such as for oxygen. It's imperative that healthcare resources provide the best value possible for both the government and its people. Health Technology Assessment, or HTA, offers an analytical process through which to systematically assess interventions and set of priorities for health investments. HTA uses explicit methods to determine the relative value of a health technology, such as a drug, vaccine, diagnostic test, or other medical device, and prioritize adoption based on an assessment of relative costs and benefits. HTAs are used by many countries around the world to identify the most optimal healthcare solution considering safety, clinical efficacy, and cost. Their recommendations help governments and policymakers make the best decisions about how to allocate scarce public resources and have the biggest impact on people's health and well-being. We believe that the HTA framework creates a vital platform for open and transparent dialogue among the many stakeholders involved in operationalizing HTA and translating recommendations to inform purchasing. Building HTA capacity in low and middle income countries will offer an additional and powerful tool to enable governments to adopt policy actions based on data and evidence, which is critical to ensure best value for the health system and equitable access to needed health technologies and healthcare for all populations. COVID-19 is a reminder that now, perhaps more than ever, such evidence-driven solutions are extremely important in enabling healthcare systems to provide the most effective preventive and therapeutic measures for the people they serve. HTA is a rapidly growing field, and we're gathering a growing body of experiences from countries across the globe that are implementing HTA. Ukraine is one such example. We work with the Ukrainian government under USAID's SafeMed project to optimize financing of the pharmaceutical sector, a key priority for the government of Ukraine, as part of their reforms to make essential medicines affordable for all. We'll be hearing their insights later on. I look forward to hearing the experiences from the accomplished HTA leaders who have joined us today in the panel and appreciate them sharing their thoughts on the HTA roadmap and how it can guide countries. The pragmatic approach laid out in the roadmap provides an opportunity for countries to chart a course to institutionalizing HTA with a pathway adapted to their individual context and policy priorities. We, USAID, are pleased to be part of this initiative and excited to take the work forward with our partners. Thank you.
Thank you, Dan and Lisa. We'll move on now to presentations on the roadmap from the core team, the core writing team. So I will start by introducing the core writing team. The principal author for the roadmap is Dr. Hector Castro. With A physician by training, Dr. Castro is a leader in global health, holding several leadership positions across different countries. And he is the global lead for infectious diseases, health financing, technologies, data, and impact at MSH. He has over 20 years of experience focusing on health system strengthening and reforms in quality assurance, assessment, financing, strategic purchasing, and provision of healthcare services. Dr. Castro served as the Chief Officer, Technical Advisor, Director, and Manager in Strategic Planning, Quality Assurance, Health Safety, and Environment for various pharmaceutical health insurance and non-governmental organizations. Dr. Castro was also the founding Chief Executive Director of Colombia's HTA Institute, and he's currently the Latin America Policy Forum Chair for Health Technology Assessment International, the network for health technology assessment agencies. Following Dr. Castro, I would like to introduce Chris Harlem. Chris Harlem is the Senior Technical Advisor at MSH in Pharmaceutical Economics and Health Technology Assessment at MSH. He is one of the core writers of the roadmap. He's a public health expert with over 14 years of experience, including medical practice in rural Indonesia, policy work at the Indonesian Ministry of Health, and academic research and teaching at Harvard. Before joining MSH, Dr. Soharlim developed costing tools and instruments for intensified mission Indradhanush on one of the largest immunization drives, and led data management and analysis of EPIC, one of the most extensive coordinated sets of immunization, costing, and financing in 6 countries. Finally, myself, Ritu Kumar. I'm a senior principal technical advisor at MSH. I work on health technology assessment and market dynamics. I provide technical expertise on various projects on establishing systematic priority setting, scaling up access to new technologies, medicines pricing, and strategic purchasing approaches. I have 14 years of experience in health system strengthening, including market shaping and access to medicines in South and Southeast Asia and Sub-Saharan Africa. I was very excited to work on this roadmap and look forward to the presentations from Dr. Castro and Dr. Saharlim talking more about the roadmap. Over to you, Dr. Castro.
Thanks, Ritu. Thanks very much for the introductions. Hello, everyone. Good morning, good afternoon, depending on where you are. Good evening. Let me start by speaking about the challenges imposed whenever we need to set priorities under challenges related to limited resources. We all know that all health systems face the challenge of managing finite resources to address unlimited demand for services. And our aspiration, whenever we're allocating those limited resources, is to bear in mind that things which matter most should never be at the mercy of things which matter least. Hence, we might even say that priority setting could be considered as an art. Next slide, please. However, what happens in many parts of the world is that the lack of coherence between limitless promise and limited resources leads to implicit and covert rationing, either through waiting lines, low quality, stockouts, inequalities, among other mechanisms. What happens in many low and middle income countries is that rationing still occurs as a non-systematic, non-transparent process that reflects the competing interests of governments, donors, and other stakeholders. Next slide, please. In order to inform resource allocation decisions like reimbursement, coverage, prices, or pricing policies, quality, health technology assessment, a multidisciplinary process that uses explicit methods similar to those of evidence-based medicine and economic evaluation, or combining both, is used to determine the value of a health technology at different points in its life cycle, with the aspiration to inform decision-making in order to promote equitable, efficient, and high-quality health system. It is worth mentioning that whenever we refer to health technologies, this could be medicines, medical devices, procedures, among other diagnostic tests, vaccines, among other types of technologies. Next slide, please. Health technology assessment is not new. It started here in the US in the mid 1970s with the Office of Technology Assessment. Later on, other countries like Canada and Sweden established their own specific and very robust health technology assessment agencies or processes. And throughout the years, different countries, mostly high-income countries, have established health technology assessment units, mechanisms, bodies to inform decision-making and resource allocation within their own jurisdictions. Perhaps one of the most reputed ones and more robust ones is NICE, the National Institute for Health and Care Excellence in the UK, which was established in 1999. More recently, low and middle income countries like Thailand, Ukraine, Colombia, Tunisia, among others, have established their own HTA bodies to inform those decisions. Currently, there are over 50 agencies in more than 30 countries around the globe, and perhaps they are growing as we speak. Next slide, please. Today, we're launching a roadmap for systematic priority setting and health technology assessment because we believe that as countries move towards achieving universal healthcare coverage, there is an increasing need to ensure the effective management and allocation of finite resources as the demand for healthcare services grows. It is worth also mentioning that we know that there are still unfinished agendas in the case of infectious diseases like HIV, TB, and malaria, while also there is a growing pattern of non-communicable diseases, including cancer, cardiovascular disease, amongst others. Still, there are countries suffering the strain due to neglected and tropical diseases, and all these without mentioning the current pandemic and the risk of potential pandemics in the future. Hence, there is an opportunity for leveraging from existing concepts, frameworks, and tools and approaches to advance priority setting and HTA, mostly in low and middle income countries. Next slide, please. This work is the result of a collaborative effort from many people, as has been said before. Our internal writing team from MSH include Ritu Kumar, Dr. Chris Harlim, as was said before, Dr. Javier Guzman, Colin Gilmartin, Dr. Anna Maris, Meenakshi Mehra, and Dr. Rabia Kavechi. But I would like to express my gratitude to co-authors and contributors outside of MSH, for instance, Dr. Calypso Chalkidu from the Center for Global Development and Imperial College, Dr. Tony Collier from the University of York in the UK, Dr. Vaya Ortwinjin from Radboud University Medical Center and current Vice President of HTAI, Dr. Dan Ollendorf from the Center for the Evaluation of Value and Risk in Health at Tufts Medical Center and current Chair of the HTAI Global Policy Forum, Dr. Iñaki Gutierrez Ibarlucea from the Basque Office for HTA and also current President of HTAI, Tara Schuller from INATA, the International Networks for Agencies for Health Technology Assessment, James Kruger from the University of Washington and current President of ISPOR, and Dr. Jin Zhao Shen from Fudan University from China. Without your support, this document wouldn't be as comprehensive and robust as it looks today. Next slide, please. The roadmap is kind of like this apple shape. Basically, what we did is that we leveraged from the heuristic stages of policy making, whereby there are at least 5 stages: agenda setting, policy formulation, adoption, implementation, and impact evaluation. And basically, whenever a context, a country, a jurisdiction decides that there is a problem related to quality, waste, inefficiency, lack of accountability that could be solved by health technology assessment and systematic priority setting, what we do through the document is that we provide the readers with different tools and frameworks that have been published from different sources in order to advance these stages. For instance, at the stage of agenda setting, we provide the readers with tools to help them seize or create windows of opportunity for HTA. conduct policy analysis and formulate HTA policies. During the policy formulation stage, we advocate for not reinventing the wheel, but for benchmarking existing good practices from neighboring countries or other countries that have been successful on their effort of implementing HTA. We also advise on conducting situational and key stakeholder analysis to assess the political economy of the process. And one thing that is key is to decide from the very beginning why, what are you going to use HTA for, when and how. And then during the adoption and implementation stages, the idea is to look at legal frameworks and institutional arrangements, assess and leverage from current capacities instead of starting from scratch. Since there is a very important to harmonize and standardize methods, we strongly advocate for developing methodological guidelines, customizing methods, particularly at the very beginning of the process, and learn as you walk via capacity building strategies. Finally, on impact and evaluation, we believe that from the very beginning, there should be frameworks for measuring the impact of HTA in order to secure its political buy-in, but also financial resources for sustained operations. Hence, we also recommend identifying key performance indicators, baseline, and ongoing data collection throughout the process. Next slide, please. The document has 6 chapters that distill from the stages heuristic model that I just mentioned before. Next slide, please. And just as way of example, here are some of the tools that we present throughout the document. For instance, we leverage from the Kingdom model for agenda setting, for seizing or creating windows of opportunity for policy action towards HTA, and we portray at least 2 examples, one from Latin America and the other one from Asia, in cases where the Kingdom model has been used for this purpose. We also leverage from the policy triangle from Waltz and Gilson that helps implementing partners and researchers to analyze the content, context, and process and actors involved into the HTA process. And finally, and again, as just way of example, we also leverage from tools like Polymap developed by Professor Michael Reich from Harvard University to conduct stakeholder analysis in order to do prospective and retrospective analysis throughout the process. I will hand it over to my colleague, Dr. Chris Uharding, who's going to help you walk through the process of developing the roadmap, and also we'll briefly discuss some about the methods implications. Over to you, Chris.
Thanks, Hector. Very briefly, let me explain how we develop the documents. We first seek to understand the barriers and facilitators to introducing health technology assessment, or HTA. In doing this, we looked at over 18,000 resources in English, French, and Spanish. We also received valuable feedback from our contributors and co-authors, and we are very grateful for their support. As previously said, our collaborators include global experts representing professional associations from ISPOR, INATA, HTAI, and among others. In the next slide, we look at HTA methods. As you can see here, different types of studies may lead to different results. There is a need to standardize the methods to reduce the uncertainty surrounding the HTA results and reports. As an example that we present here, we have 6 studies. All of these studies are about prevention for hemophilia, which is a disease affecting the body's ability to stop bleeding. Each of these 6 studies have different assumptions. And here on the right, we also see different conclusions. We know that any evaluation of health technologies will rely on assumptions. And to do it well, we will need a standardized methods. Without these standards, we would risk facing a similar situation in which we have multiple evaluation producing contradicting results. In the next slide, we also highlight methods that are often used for HTA. On the left, you see from peer referencing, rapid reviews, and costing studies, which will only require somewhat limited effort and primary data. To all the way to cost effectiveness and cost utility analysis, which of course is more robust, but will require more resources. On the right in this slide, we also discussed ways to utilize the abundance of available research and how we can transfer the learnings from different jurisdiction to your specific context. An example here is the Drummond flowchart. It looks at availability of data, relevance, comparability, and location of the study. And this flowchart also discusses the methods that we can use, which include adoption, simple adaptation, reanalysis of the data, and the use of other data and modeling. And this is important so that we can use the abundance of available research and transfer this learning to our jurisdiction and our country. Lastly, here in the next slide, we discuss the potential need for an incremental stepwise adoption for HTA in low and middle income countries. First, we want to acknowledge that high income countries has had decades of HTA developments, and they have a long list of best practices. It is aspirational. We want to reach the same level. But for countries just starting to get into HTA, we also have to be realistic, understanding what is feasible within our limited time and resources. We have to start somewhere, take the first step, and start our journey to self-reliance. So here we discuss for countries with no or non-existing HTA capacity. We recommend focusing the available resources towards conducting rapid reviews, peer referencing, safety and efficacy, and conduct costing studies. We discussed before that these methods that I just mentioned require the least amount of effort. And so that the limited HTA resources that countries have can create many timely HTA evaluations to support decision makers. There will be plenty of caveats. It will not be perfect. But this approach will produce impact fast. It's showing to be a proven concept, and HTA will become a part of the decision-making process, which will then increase the likelihood for further investments in HTA. For countries with some HTA capacity, we often see countries experience significant fragmentations. There will be pockets of expertise here and there through academia or think tanks within the country. The focus here should be to harmonize the standards in methods and reduce fragmentation. The focus here should think about creating an ecosystem and making sure that the results are valid, comparable, and of high quality. Of course, when resources are available, countries should feel empowered to undertake the more sophisticated model that we have outlined before. Lastly, for countries with fully developed HTA capacity, the focus here will be twofold. Internally, the country should focus on harmonizing and coordinating HTA efforts. Some might want to start using multi-criteria decision analysis, or MCDA, as mentioned here, which has the ability to evaluate multiple dimensions at the same time. Externally, the country should focus on connecting with international bodies and contributing to the global discussion. We hope this stepwise approach, informed by our systematic review and global experts, will help countries move fast, gain the momentum that they need, and grow their HTA capacity towards their journey to self-reliance. Thank you, and I now return the floor to Ritu.
Thanks, Chris, for that insightful presentation, and thank you, Hector. So now we move on to the panel discussion. We have a power-packed all-women panel today of global experts from different parts of the world. We're going to be starting off with Dr. Oresta Pinasco. She is the current director of the HTA department at the Ukraine State Expert Center in the Ministry of Health. Ensuring the implementation of best international practices on HTA in the healthcare system of Ukraine. Since 2017, Oresta has held the position of the president of the ISPOR Ukraine chapter. She has professional experience across various fields over the last 20 odd years. She will be talking about Ukraine's experience in implementing HTA. As Lisa previously highlighted, Ukraine is a recent entrant. They just established their HTA agency in 2019. And Oresta will reflect on the journey to implementing an evolution, the evolution of the HTA agency, and comparing and contrasting to the Chapter 1 in our HTA roadmap, and providing insights into HTA's experience. Over to you, Oresta.
Good morning and good afternoon, dear colleagues and participants. First of all, thank you very much for organizing committee of MSH USAID for inviting me to participate in this very exciting panel. Regarding the steps of institutionalization of health technology assessment in Ukraine, I will present in my short presentation. First steps in HTA developments in Ukraine were by academic society since 2009, and in 2016 was established independent advisory body of the Ministry of Health of Ukraine Expert Committee on Selection and Use of Essential Medicines. In 2018, by the Cabinet of Ministers decree based on WHO recommendations, was approved first national drug policy in Ukraine. This is defined as political commitment and a guide for action to ensure availability and rational use of effective and safe medicines of appropriate quality according to the European practice of national drug policy. The implementation of HTA is one of the main tasks of this document of national drug policy in Ukraine. And the first legislation for HTA, which was defined for assessment of medicines for inclusion to the national list, was approved in 2016-2017. For the first time in Ukraine, country-specific HTA guidelines were developed based on the best international practice, based on ISPOR, UNET HTA, HTAI methodological recommendations. In 2019, the HTA department at State Expert Center of Ministry of Health of Ukraine was established. And this is the next step in the institutionalization of health technology assessment in Ukraine. Among the main ongoing activities and planned activities are conducting health technology assessment for informing decision-making process in healthcare regarding rational financing of medicines and other health technologies to offer the best patients value and development of HTA HTA in Ukraine. In 2020-2022, further institutionalization and strengthening is ongoing and will be implemented. One of the main successes are development of HTA roadmap. So to deliver appropriate tasks and achieve desirable outcomes, the new established HTA department has to become a trusted, independent, and fully functioning entity. And for this purpose, at the main step of building of strong, effective institutions and to align daily activities with long-term goals, HTA department together with the Minister of Health and leading by the Minister of Health with the support of SafeMed, USAID project and MSH were conducted National HTA Forum, which was held first time in February 2019 to develop HTA roadmap in Ukraine. The HTA roadmap defines clear and precise actions that have to be fulfilled to achieve the strategic objectives. The HTA roadmap guides processes so HTA department become a strong and a reliable entity within HTA informed decision making in Ukraine. Currently, this year, we are developing in Ukraine HTA legislation. In particular, this is Cabinet of Ministers decree project. So this is in process for final stage of approval. And we had last week the second National HTA Forum, which was a perfect platform organized by the Minister of Health and support of SafeMed project for communication with all the stakeholders of HTA process in Ukraine, with the main national state authorities, with the expert environment, pharmaceutical industry, scientists, clinicians, pharmacists, and patients. According to the first chapter of the roadmap. So we see that the main drivers for HTA establishment and development, and in particular for Central and Eastern Europe, are health system context. This is the demand for the quality healthcare grew. Countries need to reform healthcare system according to the best international requirements, and political support. Countries wanting to join EU and needing to comply with certain requirements. Also globalization, so joining different professional specialized networks, and local capacity, which is one of also the main drivers and key successful points to achieve the best results in HTA implementation. So the main drivers of institutionalization of HTA in the countries where this is on the early stages are very well presented, and in our local context in Ukraine, we see these key drivers of success. First of all, to move step by step with a clear plan and development of HTA roadmap and the support of stakeholders and national and international partners. Thank you very much.
Thank you, Aresta, for that really insightful presentation on Ukraine's journey and how they have leveraged the global experience and the key drivers and barriers to institutionalization of HTA in Ukraine. Next, our next panelist is Dr. Adriana Maria Robayo Garcia, who is the current executive director for Colombia's HTA Agency, IETS. Adriana is a surgeon from the National University of Colombia and a clinical specialist in internal medicine and nephrology. She has over 20 years of experience in clinical, academic, investigative, administrative, and management positions and numerous boards of directors in Colombia. Most importantly, she is the president of the Colombian Association of Nephrology and the general secretary of the Colombian Association of Scientific Societies in 2018. Dr. Adriana is going to reflect on Chapter 3 of the roadmap and talk about the policy process of institutionalizing HTA in Colombia. There has been a big history of HTA advancement in Latin America over the last several years. And Colombia established its HTA agency in 2012. And Adriana will reflect upon the steps and the policy that made the policy change and drove the institutionalization process. Over to you, Adriana.
Thank you very much, Ritu, and thank you very much for MSH for your kind invitation. And in Colombia, we now are thinking of, we are sure that it could be a good, an important tool for the development of the HTA in all the region. I want to show you some points about Colombia and this process of the HTA. Colombia is right now a country about 50 million of people with 70% of health coverage and have a comprehensive health benefit plan. And we additionally cover individual health events by health. We work actively in increasing our population benefits and increase the access to the most remote regions of the country on the poorest in our population. Actually, we are working by a country actively increase all these benefits, and I want to show you how we do that. The institute, the IETS, began operations in 2012 by law, and since then we are working actively with different actors in the system. We are currently working in HTA, budget impact analysis, clinical practice guidelines, and we are working with the defining of the definitions of the drugs and technologies inclusions for our country. We develop and review our methods in every day, and actually with the COVID, we work in a clinical consensus and making a technology evaluation. As a part of the COVID country committees, we are working in the access to the vaccines, participation, different decisions for the COVAX mechanism, and in the next months, we are working evaluation all the information for the vaccines for the bilateral agreements. In the region, we work together with the other countries like Brazil, Mexico, Chile, Argentina, and Colombia, of course, because we have a bigger development in these items, but we can work too with Uruguay, Costa Rica, and Peru. They are making two biggest advances. In the chapter 2, I found it very interesting because it has very useful tools that can put all of these topics in the reality. It works about 3 different points. It's about the problem. You have to see what is the real problem. After that, you have to work with the policies. And at the end, you have to make some kind of politics to get all this together and bring to the HTA for the country a reality. It has a very different methods, like Hector said before, the methods of the actors, the methods of the problem policy and politics, looking about the context and the process analysis of this. And it's very interesting for us because in the next month, we are going to have a very good discussion in our country because we are in front of a new reform of health. Maybe we have a lot of different tools in our system of health, but we have to put all together to work in a better way to give a real health and results for the population in terms of health. I found it very interesting to the region in general. In the region we are working, I said before, in a network, we have each year a different policy forum for the REDEXA is similar to UNETA in Europe and the other agencies groups. And we have another group is EvidNet. EvidNet is very useful to us to discuss this kind of politics to the practice too. And we are working in the Latin American Policy Forum of the HTA, and we hope in the 2022 we are with you in Cartagena looking for these new technologies. I found and in the institute we are working a lot, maybe in the next month with these tools because I said we have a reform and but in this right moment we are working to the value pricing for value for the next month. It's a new thing, but we worked with that before, and maybe in the next months in front, we have a real solution for this for the country. The sustainability in the country is a very big issue. The access and the results of of that is a big issue. So we expect this roadmap can help us to give prices and very specific and very precise and with the step by step to give this kind of evolution to the next years in Colombia. This is a very interesting moment in Colombia because we are working with the different societies of medical people, and we are working with the government, we are working with the patients, and we are improving our process of participation with them. And we speak also with the different pharmaceutical industries and technological industries, and we are all of us giving a good kind of speaking and dialogue in the country about these methods, and we hope the reform includes in a very strong way the HTA for the sustainability of the country in the next months. Like I said, we work about method. We work with the people of the GAN. We Cochrane people. We are a part of the whole different methods collaboration in the world and in the region, and we are all the time very excited for sharing all this knowledge and for learn and to especially to adapt and see how it could result in our region for all of this development and how we can introduce them in a very effective way. It could be the things I want to say today. Very happy with the roadmap and congratulations for all the people of the MSH for doing this very good product for the whole community of HTA. Thank you, Ritu. Is the thing I want to say today.
Thank you, Adriano. Thank you so much. I think there's a lot to learn from Colombia's experience and how they've driven the policy process and generated political commitment across the country and are looking at financial sustainability. And it's great to know that the roadmap will help them in that process of thinking through and building other regional collaborations as well. We are now going to move on to our next panelist, which is Ndinda Kusu. She is the country project director for the Medicines, Technologies, and Pharmaceutical Services program in Nairobi, Kenya. She has over 15 years of experience in pharmaceutical care and 10 years of experience in human and institutional capacity development, developing policies and guidelines and curriculum, and conducting on-the-job training and professional development. She has worked with the Kenyan Medicines Regulatory Authority in strengthening pharmaceutical legislation, quality assurance, and pharmacovigilance. Ndinda is going to talk about Kenya's experience. Kenya is a new entrant or a recent entrant in the HTA space. They have made a commitment to UHC and building a sustainable UHC program, and HTA is a crucial component to that. Ndinda will reflect upon how the implementation for HTA is and the vision that Kenya has, the previous history of HTA within the country, comparing and contrasting it to the Chapter 3 on implementation and institutional structures for HTA roadmap. Over to you, Ndinda.
Thank you very much, Ritu, for giving me this opportunity to contribute to this session on the launch of the roadmap of systemic priority setting and the HTA roadmap. Kindly allow me to look at HTA using the lens of UHC from a Kenya perspective, and also weighing in at trying to apply it to the African context. So when I look at Kenya, it's really a country that is committed to UHC and moving beyond essential medicine lists to benefits packages, and also thinking on using HTA for such purposes. And this has been ingrained in the Kenya Constitution, which was promulgated in 2010, which really guarantees health for all Kenyans. And that is well articulated and states that every person has the right to the highest attainable standard of health, which includes the right to healthcare services, including reproductive health. And further, the Constitution says that nobody should be denied emergency treatment for either loss or injury. And as we look at the Kenya Constitution, we see that this is really in tandem with the WHO Constitution, which declares that there is need for everybody to enjoy the highest attainable standard of health, which is really a fundamental right for every human being. So looking at Kenya and rewinding back to 2018, our current President Uhuru Kenyatta committed to achieving UHC by 2020. And we put things in place to ensure that there's progress in this front. And attainment of UHC is one of the 4 big agenda items for President Uhuru Kenyatta. And as we speak, we've strengthened, and there are efforts to strengthen the National Health Insurance Fund with a consolidation of the fragmented insurance schemes, covers under health under the NHIF to ensure that we have expanded health coverage. We've also seen that, the country has established priority setting practices, and this is already envisioned in the national policies and instruments. As a country, we have a national health policy, and we have a national strategic plan that supports UHC. In addition, the country, through the leadership of the President and also the Cabinet Secretary for Health, established a panel to really look at, UHC benefits package, and we've developed a Kenya Essential Package of Health Services, which again lists the priority services to be provided by the public health sector, and it will also guide county governments which are responsible for health service delivery. The counties in Kenya are responsible for health services, which is really a devolved function, and this KEF, which is the Essential Package for Health Services, is actually going a long way to support that. In the recent years, we've also seen the country, the Ministry of Health, and specifically the National AIDS and STI Control Program and the National AIDS Control Council conduct some assessments to develop cost-effective differentiated care pathways for HIV treatment, which again will lead to quality improvement of service delivery. In 2019, through USAID MTAP's program support, the country revised the Kenya Essential Medicine List, again, which was done in line with the global best practices for management of essential medicines and health technologies. And during this revision, the entity that was responsible for doing this incorporated good practices and expanded the products that are covered and recommended other products to be available even to other levels of care where we were not seeing such products available. A case in example is the non-communicable disease medicines, which were, taken to the lower levels of care that did not have NCD medicines in the past. What is important to note is that this revised Kenya Essential Medicine List is part of the UHC benefits package, and the products were carefully and systematically selected using evidence-based process, considering the public health relevance of efficacy, safety, and cost effectiveness. And the National Medicine Therapeutic Committee, which is responsible for that, really took a lot of HTA-related principles into consideration. While still looking at UHC in Kenya, there's a UHC benefits advisory panel, which is responsible not only for determining the best buys, that is based on cost effectiveness, budget, impact, safety, or efficacy, but this panel also considered the elements of inclusion, exclusion criteria for benefits package. The term has ended in June, but they made recommendations and there are considerations in the country to sustain the role going forward, either by extending or forming a similar panel. What is important to note is that this panel prioritize the institutionalization of HTA and data collection frameworks as key to implementing the health benefits package and attainment of UHC in Kenya. So when I read the chapter 3 of the roadmap and tried to see how best we can leverage the document in terms of adoption, implementation of HTA in a country like Kenya, using Kenya as an example, I would say that, Kenya already has set areas which are explicit and have, an evidence-based approach for HTA to be applied and to be useful. The country has had interest in HTA and has actually had benchmarking visits to some of the countries that are implementing HTA. A case in example is Thailand. Some of the opportunities, we can use and adopt and implement HTA are the examples I mentioned before, and we need to employ that as we continue to update the UHC benefits package, working closely with the National Health Insurance Fund to offer cost-effective UHC scheme, which ensures that there is good population coverage, wide services, and also there's financial protection. It's important to really apply HTA to unpack, prioritize the services with a clear understanding of the related costs for all the inputs, because currently the scheme has lumped everything and there's no clear understanding of what drives which costs. Indeed, sometimes the cover cannot even take care of the services and also, the respective, medicines that are prescribed. And it's important to apply HTA to guide the premiums, to guide reimbursements. The other area is really considering HTA as we determine and update the Kenya Essential Package of Health Services, as we determine what conditions, what services, what tests, medicines, and the related costs by the level of care in a systematic manner. As we look into the future and continue updating the essential medicine list and other essential health products lists, based on global and best practices and the local context, it's important to ensure that we employ HTA practices and use an evidence-based process, considering, the public health relevance, cost, efficacy, safety, and also just how effective they are as we decide which products are going into this list and are they affordable or not. When I again look at the institutional structures and stakeholder engagement that are clearly highlighted in the roadmap, it's important for countries like Kenya and other countries in Africa to learn about, the examples of the various institutional structures in other countries and what could be applicable to Kenya and other countries. So, for example, the UHC Health Benefits panel in Kenya already constituted of academia, health economists, health system experts, epidemiologists, health professionals. It had, of course, the Ministry of Health and the representation from, professional associations and also the counties. It's important to ensure that there is wide stakeholder engagement, and a key consideration in the country would be how to implement, to institutionalize HTA. Will it be at the Ministry of Health? Will it be an independent entity? These are some of the things that the country is thinking about. But it's important to ensure that whichever way the country goes, there is good political buy-in and support. We've seen in chapter 3 that, there are two common approaches for institutionalizing HTA, which can be top-down approach or, bottom-up. Countries may decide what approach works best, if it is within the ministries of health, or if it is an independent entity. I know as a country, there was a conversation, could it be KEMRI, whether it's, within the Ministry of Health, but still there's some work and some discussions and some thinking that needs to go in place. But there is really good commitment from the highest level of the Ministry of Health to institutionalize HTA, which is already factored in even in the report that came out of the UHC benefits package panel. So finally, just trying to weigh in and reflect on what would be the potential usefulness of this roadmap for Kenya, and really to highlight that this launch is timely for Kenya and other countries in general, and this roadmap will help with strategy and operational planning. We have policies, we have strategic plans, but we need to integrate HTA into the various priority setting exercises and make sure that we engage the prioritized and the key stakeholders, identify them and involve them, and have clear roles of each of the various stakeholders and institutions to be engaged in the process to ensure that the findings, the recommendations are owned and are also evidence-based. HTA will also help us
Sorry to
us in
interrupt,
Kenya.
Kusu. I just wanted to say that, in the interest of time, if we could uh, wrap up a little bit and have the rest of the panel continue, and we can come back to Kenya during the Q&A session. Thank you.
Thank you very much, Ritu. So to wind up is to say that we are ready to apply HTA and harmonize HTA practices across the different exercises, whether it's within the Kenya Essential package of health services, whether it's within the UHC benefits package, whether it's in the reviewing and finalization of the key documents. And we need to borrow from the principles of the good practices that are articulated in Chapter 3 and apply that. And again, to reiterate that adoption of HTA is really key for UHC, for Kenya and other countries, and we need to adopt and translate HTA into policy and action. Thank you, and over.
Thank you so much, Ninda. It's great to learn about the previous history and established practices of priority setting in Kenya already, and how that can be leveraged to think through the institutional structure for HTA in the future, and how the roadmap will help in providing other examples and experiences from countries, to think through that process. I also wanted to highlight that previously, as many of you have seen in the agenda, that we had another expert from Sub-Saharan Africa, Dr. Johnny Mueller, who was scheduled to speak, but because she was unwell, Adinda stepped into her shoes. But we do have her joining today, and she will be addressing questions during the Q&A session. She is a senior researcher from South Africa and has a faculty position with the University of Pretoria. She's also the chair for the Developing Countries Group at HTAI and has a broader experience from the global community of HTA, as well as the African subcontinent as well. So moving on to our next panelist, we will be hearing from Dr. Grace Huang. Dr. Huang is the director for the HTA department in the Center of Drug Evaluation in Taiwan. Her department leads the HTA for the government of Taiwan. She was also the board of directors at Inahata from 2016 to 2018, and is currently on the board as well since 2019 for HTAI. She will be reflecting upon Chapter 5 and speaking to how Taiwan is working on evaluating the impact of HTA and their experience on as they scale up HTA within the country as well. So I will hand it over to Grace.
Okay, thank you, Ritu's introduction. Good morning, good afternoon, and good evening, ladies and gentlemen. I am so privileged and honored to be given this opportunity to speak in front of you today about the status of CDE HTA in Taiwan. First, about our national health insurance. Since its implementation in 1995, the National Health Insurance Program in Taiwan has successfully offered universal and high-quality health care to all its citizens at affordable cost. And Taiwan started conducting health technology assessment in 2007 to support the National Health Insurance Administration in its reimbursement policies regarding new drugs by considering the health and well-being of all citizens, medical ethics, and the cost effectiveness within the financial framework of the NHI program. And the division of HTA operates under the Center of Drug Evaluation Taiwan. Notably, the HTA process draw from the HTA program of Australia like PBAC, Canada like CADIS, and the United Kingdom like NICE. Later, HTAs were extended to include medical devices in 2011 and medical service in 2014 and social care in 2016. So the ultimate goal of HTA is to support the national authorities' maximization of public health benefits. The HTA team, our team, primarily assess the clinical comparative effectiveness and economic evaluation of new drugs and medical devices to support the NHI program's decision making. The HTA team also conducted various HTA-related research projects commissioned by other health authorities under the Ministries of Health and Wealth. Furthermore, the HTA team is accountable for the development of the HTA process and methods. And promotion the international operation, organization of education and training programs, and provision of the consultation service to pharmaceutical manufacturers who apply for NHI reimbursements. And there are two types of HTA reports produced by our team. First is the assessment reports for NHI reimbursement decision. And the second is the commission research project from other divisions under the Ministry of Health and Wealth. Assessment report for the NHI reimbursement decision, like application for reimbursements, are received by the NHIA, and NHIA commissioned the HTA team for assessment of each technology. For every new reimbursement request, our team produced an assessment report by executing a clinical and economic assessment, include the clinical efficacy, comparative effectiveness, cost effectiveness, and the budget impact of the new technology. And the type of the assessment report for NHI reimbursement decision include the breakthrough drugs, which are classified by NHIA and claimed by sponsor. And the second is the general new drugs with new medical, molecular entirety, new formulation, and new rules of administration, as approved by the competent authorities. And the third is the new medical devices. The HTA assessment report needed to complete within 42 calendar days as requested by NHIA. So in Taiwan, our HTA report just like the rapid HTA report. Then the assessment report is submitted to the NHIA to support the NHI reimbursement decision. And the Pharmaceutical Benefit and Reimbursement Scheme, a joint appraisal committee comprising government officials, health professionals, manufacturers, and consumer representatives, final decides on the appropriateness of the new drug medical devices for reimbursement or not under NHIA Act. And the committee member of PBRS are selected every 2 years. Our team also accepts commission from other health authorities under the Ministry of Health Wealth, just I mentioned previous, like the NHIA also, and also the Central for Disease Control, CDC, and the Social and Family Affairs Administration, and the Health Promotion Administration to conduct various HTA-related projects. And the time frame for each project is usually 1 year, so our team have more time to finish the project. And some projects are less longer, especially when a cost effectiveness analysis model is needed. So there are a variety of HTA systems in the Asia region. However, due to the language gap in Asia, we use example from Western countries for HTA experience. It would be best if Asia countries could cooperate each other learn from each other, and share our experience with each other. So bottom line, overall in Taiwan, the 12-year implementation of HTA has not only supported the government's decision-making, but also enhanced patient care. Furthermore, patient evidence and patient feedback had been highlighted, and the patient care pathways have been transformed through patient involvement in HTA. So right now in PBIs, a patient representative could regularly attend the PBIs meeting. In conclusion, HTA's value has been determined by both government and the social aspects in Taiwan. Thank you for your listening.
Thank you so much, Grace, for that insightful discussion on presentation on Taiwan's experience and how patient engagement and social engagement has driven the impact of HTA within the country, and how Taiwan has leveraged the global experience as they are advancing HTA in the country. As we can see from all the presentations of the panelists, that every journey towards HTA has been unique, and there is no one size fits all. The roadmap allows for flexibility and to think about these arrangements and the roles and the remits of these agencies. And so I think it's a very timely discussion that we have, and now I'm going to open up the floor for Q&A. We already have several questions, given to us through the chat box. Thank you, everyone, for your continued participation. I am going to kick it off with the first question for all of the panelists, and I'd like to remind you that we do have Johnny Mueller as well talking about the experience in sub-Saharan Africa. So for the first question for all the panelists, there is no perfect model to conduct HTAs. So some countries may be interested in using a single all-encompassing unit of measure for evaluating the economic and health and legal impact of a technology. So they use measures like DALYs and QALYs. However, other countries take a two-step approach, looking at the safety and efficacy of the technology first, and then moving into the economic impact, into budget impact analysis or cost effectiveness analysis. So how do you see recommendations in the chapter 4 of the roadmap in your region and globally, including those countries who are just starting out to explore HTA, and what are your recommendations on these different approaches to measuring the impact? Grace, Adriana, Johnny, anybody can step in and
Yeah. Okay, I start. I feel you have to review and have the exact points and see how you can choose them and use all the tools and to give to your country the best application and adaptation of this whole method. For example, for us, as I said before, we are working in a new reform. We are working in price for value, and we are working in many things in the government to improve the access and improve the results in health for the people. But we have particularities, as you said before. We have to make all of these in some way has to applicability to Colombia, because if not, you can put this without any kind of reasoning and thinking about this, the particularities of your country. So we have a new insight about the stakeholders, how do you have to work with them, how you work with the patient and the medical societies to get to the policymakers, think about these different topics about HTA on the uses in the sustainability and improving the health of your country. I think that.
Thank you, Adriana. So we'll move on to a next question, and I'd like a chance to have maybe Johnny step in and respond. We have a question from Nigeria where they're asking, in countries where out-of-pocket expenditure for health accounts is over 70% for total health expenditures, how effective can HTA be used to drive policies and decisions? Over to you, Johnny.
Yes, thank you, Ritu, and thank you, MSH, for having me here. Yes, that question actually came up in a previous web meeting that we have had. And when we think about, there are many LMICs which are in the same position, right? So what is the solution for those countries where there is a movement from bottom, or at the patient level or at the clinician level for input from HTA, but on the other hand, there is either not enough capacity, or depending upon the political setup, there is also not a room for transparency, which HTA brings. So I think it's my own opinion though, there has to be also advocacy and movement from the patient level and the clinicians, that that we want to be that they should be also involved in the decision making process, but it's unfortunately it's a long way to go. Thank you.
Great. I'm going to hand it over to Hector, who has something to add as well on this topic.
Yeah, no, that is a very interesting question. And I would just like to echo something that Johnny just mentioned. And the benefit of having systematic priority setting processes is that it allows different stakeholders to be involved within the full process, and patients are key. And if in those countries where out of pocket is as high as 70%, 60%, as it happens in many sub-Saharan regions, it would be good to involve patients during the horizon scanning stages of the process to identify those technologies, those medicines that represent the highest burden for out-of-pocket expenditure, to be kind of involved into the process, and actually, as Johnny mentioned, to kind of go for advocacy for those to be listed as perhaps priority one for being included into the benefits packages, now that some of these countries are moving towards national health insurance systems or national health systems. The other thing is that using HTA could serve inform not only reimbursement, but also even co-pays and quality standards of healthcare, which actually might also be able to indirectly reduce out-of-pocket expenditure if you privilege the prescription based on the best available evidence of medicine A, which is good value for money, versus medicine B that may be more costly and perhaps less beneficial for the patients. Over. Thank you.
Great. Thank you, Hector.
Sorry, Rita, one thing, I just want to what Hector said, and I know we're running out of time, but in HTA, we have seen, and I'm sure Hector can also say that involving stakeholders in the whole continuous process is benefit to the patient at the end of the day. Thank you.
Thank you, Johnny. I think this is a great segue into the next question. So we have a question from Professor Collier and a linked question directly for Aresta, which is basically Professor Collier saying that, HTA is often seen as a threat to policymakers, by policymakers, because transparency is always not welcome. So for Aresta, how do you build political will? This remains a key challenge for many LMICs. And how did Ukraine tackle this problem? And how long did this process take?
Thank you very much for a very good and important question. As I mentioned in the beginning, so steps of institutionalization of HTA and implementation and use into practice. So it was a journey since the beginning of educational programs and then implementation into the legislation documents. Effective communication and presentation of the need in the healthcare system. As you know, in the recent year in Ukraine was changes in the healthcare system financing and overall complex healthcare system reform. And in this way, there was a demand by politics and by expert environment in real useful tools which will be helpful for making decisions regarding selection of medicines effective and cost effective for their future financing. So continuous effective communication and expert support with and work with political environment is must be done in this stage.
Thank you, Arisa. I know there's lots of questions and we're quickly running out of time. We'll take one more. This is a question on, given the current focus on COVID-related health technologies, how has that impacted HTA work on other programs? Has there been a bottleneck into the introduction to new technologies? Maybe, Grace, maybe you can talk a little bit about that and give you a chance to speak to that.
Yes. In HTA, the HTA state goes to support the health authority to maximize the public health benefits. So I agree with that. Oresta said that communication is very important, and during the 12 year we try to communicate with different stakeholders and face the high cost of medicine and face the high impact technologies. We also use the communication with different stakeholders, and we give the evidence base to persuade them or to for assessment report for their reference to the decision making. So I think Haram scanning right now we try to do that, and in the future precision medicine also we face. So how to deal with such methodology and how to cooperate each other, even communicate with each other, I think is very important for us. Thank you.
Great, thank you. Maybe we have, okay, we're really running out of time, but I just wanted to say that if, for other questions and for all the people online who would like to access to the roadmap, please do reach out to us and our team, go to that link that's provided on msh.org/HTA roadmap for further information. Finally, I'd like to really thank everyone, our esteemed panelists, our speakers, leadership from MSH and USAID for speaking today and for participating, and to all the participants who joined us today. And finally, the team that has been working behind the scenes and setting all of this up, Laura, Santi, Christine, Rajita, Min, and others. I'm sorry if I missed anyone, but thank you so much for such a great and insightful discussion. We look forward to hearing from all of you in the future and collaborating. Thank you.